Hi, everybody. Can you hear me? So this webinar is a first. I've never done this before, and that is I didn't have time to make the slides. I mean, the good news is we have a presentation for Phoenix, and we have a fibromyalgia workshop, and the advanced slides are all updated. The bad news is that I haven't had time to actually make the webinar slides. The title of this webinar is Take It Apart. So the last couple of months, I have had really complicated, difficult patients. This is the first time ever I haven't had the webinar slides written at least a week before. I worked on these last night and then actually couldn't stay awake any longer. So started them, and we're going to make it live together. That's how it's going to go. What I found out treating FSM patients, especially the really complex ones that tend to come and be treated at the end of the day at the seminars, and the really complex ones that tend to come and find me at my office, each case sounds horrible and complicated and difficult. And the patients' lives are usually horrible and complicated and difficult. But to treat it with FSM has turned out to be really a matter of just taking it apart. So this patient came to the seminar, I think, in Cleveland. She's the first one. She was 32, 30, 28, in there someplace. She had 3 injuries in the last 6 years. Her major complaint when she emailed me was light sensitivity, severe light sensitivity. That sounded straightforward. It sounds like I'm treating a head injury, right? So she's asking to be treated for post-concussive syndrome. And when she got to the seminar and gave me the history, it turns out it's a little bit more complicated than that. So the first injury was she was downhill skiing, fell, and landed flat on her face on the snow. I don't know if you've ever been downhill skiing, but snow is not soft. It is hard packed, kind of crunchy, a little bit like hitting concrete. She landed on her face, got up. So she was sort of fine at the time, didn't realize till she got to the parking lot that she had a concussion. She started with nausea and light sensitivity. And within days, she had the symptoms of post-concussive syndrome. And it included severe tension headaches and pain in her right eye that progressed to severe light sensitivity, cognitive problems. At the time, she was working as marketing director for Whole Foods. And I kind of forget if she stopped working after that accident or after the next accident, in which she was rear-ended at 30 miles an hour by a large pickup truck while she was driving a small car. As you recall, in an accident, the law of gross tonnage is the only law. So when she said she got rear-ended at the second accident, I said, okay. And then she had a third accident that was just 15 miles an hour. But the 30 miles an hour, that was the one that really did her in. And I think that's after that one that she stopped working. Then it occurred to me to ask her what she was driving and what hit her. So mass, the size and weight of the pickup truck hitting a small car, the lines of force and the amount of force is huge, almost incomprehensible. So she had a concussion again, her headaches, her eye pain, and her neck pain got worse. She started having body pain, and she was diagnosed with a peripheral neuropathy because she had pain and tingling in her hands and feet. That I'm being quiet because I want you to think about that. She had pain and tingling in her hands and feet. Then she said that the light sensitivity became intolerable and created pain in her eyes and her face, to the point where when she encountered bright lights, her whole face, especially on the right side, would become exquisitely painful. There's a lot of neuroanatomy and neurology involved in this, and we'll bring you up to speed to the extent that's possible. So then the third accident, she was rear-ended at 15 miles an hour about 2 years later. So fall on her face, smashed the front of her face 6 years ago. 4 years ago, 2 years after the ski accident, rear-ended at 30 miles an hour by a pickup truck. 2 years after that, rear-ended at 15 miles an hour. And here we are 2 years, I think, after the smaller auto accident. She had so much eye pain and pain up the back of her head that she's had facet injections. She's had radiofrequency ablations of certain facets. She's had epidurals. And the pain in her eye and at the back of her head was so bad that she looked everywhere for help and ended up on the internet with a surgeon who does nerve decompression surgeries. He does surgeries to release nerves from the surrounding fascia. She's had 3 of those surgeries. One of them was at the occiput, where he peeled away the trapezius and, using blunt dissection, peeled away the scar tissue between the trapezius and the occipital nerve at the CO, C1, C2 space. So the surgery reflected, cut the trapezius and the splenius away from the skull, reflected them back so that he could see the scar tissue around the nerve, and then, using blunt dissection, peels the nerve away from the fascia. And that helped the headaches for quite a while. And then, because her eye pain was so horrible, especially the right eye, she's had 2 or 3 of these nerve decompressing surgeries to the trochlear nerve, which is the nerve above your eyebrow. And that was to relieve the eye pain. When the first one didn't work, they did a second one. So you might be able to tell from the tone of my voice that I'm not overly fond of these kind of surgeries. And so she's on medication, Lyrica, opiates. So what did we do? So this is the part where you're actually going to see me build the slides. Can I do this? Can I push escape? Thank you. Okay. So how do you take that one apart? We good? Okay. So how are we going to take that one apart? So what symptoms did she have? She had pain up the back of her head. What nerve is that? Well, that's the occipital nerve. So what are you going to do for that? So we set up machine number 1 from the neck to the top of her head. And that one ran 40 and 396, right? Polarized positive. That's machine number 1. Second set of symptoms was pain and tingling in her hands and feet. Okay. When I showed her the fibromyalgia pain diagram and asked her, is that your pain? She said yes. And she only mentioned the pain in the hands and feet. I had to ask her, do you have any pain in your elbows? So it wasn't just hands and feet. It was elbows, hips, low back. All right, we know how to treat that, right? So that was machine number 2. And that was just 40 and 10. Neck to feet. Polarized positive. All right. Then her biggest complaint is this pain in her eye. Now, do you remember that the C2-3 facet joint refers pain to the eye, so it feels like basically a hot poker. Right? So take it apart. Machine number 3 was neck, chest, subacute facets. So that is to treat facet. Okay? So that was the eyeball pain. Now, once the pain in her head, the back of her head, was better. So we checked sensation at the C2 nerve root, and it was hyper, not numb. The nerve was still connected. It was just hypersensitive. So that's why we ran 40 and 396. Okay. So she still had pain in her right eye. So the first machine, we moved machine from the top of her head to her eye. Now, closed eyes, you don't want current going through the eyes. And I put it just under the eyebrow. And that should take care of. And so for the trochlear nerve and for the OPHTHL, ophthalmic branch of 5. 3, on the back and abdomen. So she had post-concussive symptoms. So there was one machine, back and abdomen. So that was number 4. And that we ran concussion, TTH, and concussion, and vagus. So that's all of those are alternating. We ran TTH because she kept having not only accidents and stuff happen, she had to have picked some of the most invasive, unproven iatrogenic injuries that I've ever seen. It was pretty grisly. So the second treatment for the pain up the back of her head was to deal with the scar tissue, right? So anytime I touched the back of her head to touch the upper trapezius, we wanted to treat, so the second third treatments. We treated scarring in the nerve and the fascia, and reduced the pain, but then increased the pain. So we had to go back to 40 and 396 to take that pain down. Okay. Then the surprising thing was this pain and light sensitivity. So pain in the right eye and light sensitivity. Let's go look at that. So light sensitivity. I assumed it was the fact that the pupil didn't constrict fast enough. Okay? What dilates your pupils, right? The sympathetics dilate. The vagus and parasympathetics constrict. So this light sensitivity is a function of autonomic imbalance, basically, right? At least that's what I thought. So, neck to eyes. Somebody looked it up, and the trigeminal nerve the trigeminal nerve goes to the ciliary ganglion. And as it comes out of the jugular foramen, the vagus mixes with the trigeminal nerve. This doesn't exactly mix, but that was what we thought at the time. So into her eyes, we ran 40 and 562. We ran 94 and 81 and 49 with 109, in addition to running 40 and 396. And then the second or third time we treated her, sorry about the frogs, I don't know what that's about. Second or third time we treated her, she remembered that her cornea was not exactly scratched, but inflamed. So we got the anatomy book out, and I'm not going to open it here, but think about what happens. Oh, and also all of the muscles around the eye and the eyeball, eye socket, was painful. It feels like it's in my eye socket. Okay. Feels like it's in my eye socket. So we got the anatomy book, anatomy app actually, and look at the eyeball. In a perfect world, if I'd made these slides a week ago, we would go look at the picture of the eyeball that we saw that night in the seminar, because right now it's burned in my head. The muscles that attach your eyeball inside your skull socket those muscles have tendons that attach just next to the cornea. Now, remember how the shoulder tendinopathy creates trigger points in all the shoulder muscles? Well, if your skull stops, the eyeball does not. It goes forward at whatever speed your head hits the snow, right? What's that going to create? Tendinopathy in the muscles in the eye socket. So that was the thought process. What's finally occurred to me after all these years is that you can look up the protocols and the frequencies in the core of the advanced. That's straightforward. The thought process is what makes complex treatments sensible. And when you get easy patients are easy. You can do 85% of what you do with what you get in the core. The light sensitivity. So the next treatment we treated the cornea, the frequencies for the cornea, which I don't remember. You can look them up. Inflammation, torn and broken, vitality in the cornea. Okay. And then she said, that feels better, but my eye socket hurts. Well, there's nothing in your eye socket. At that point, the facet was quiet. Referred pain from the facet was pretty much gone. Why would her eye socket hurt? And if you pressed gently on her eyeball to move it from side to side, it was painful. If you look at the tendons, we treated torn and broken in the tendons that hook the eyeball muscles to the eyeball, and that reduced the pain. That was interesting. So I saw her Friday, Saturday, Thursday, Friday, Saturday, Sunday. I saw her 4 days. Ultimately, so she had 4 treatments, and every time she came, we did the same thing: supine cervical practicum, facets. Each night, pain was better. Light sensitivity was always a problem, especially the headlights on the way home. She drove, well, her parents drove her 2 hours each way to be treated. Okay. So Sunday, we did the treatment. The pain was, I don't know, 2, 3, which was pretty good. And there's a small adjusting instrument that chiropractors and some PTs use. And I mobilized C1, 2, and 3 joints that don't move are inflamed and degenerate. And then her pain was a 0. Light sensitivity was better. And I referred her to PT. So in, I don't know, 6, 8 years, the follow-up was physical therapy. Everything she had done to her was passive. The surgeries, injections, the RF, absolutely nobody did anything manual. Obviously, you can't, if you're a chiropractor or a PT, you can't adjust or do any sort of high velocity moves in the upper cervicals because the facets are so jacked up. But physical therapy, she has a custom care that basically does what we did on 4 machines. So she can run neck pain, nerve pain, vagus, and concussion. Facet pain. That's pretty much, that's pretty much what she has. So what looked absolutely impossible became manageable when you took it apart. And then the therapy, she is already seeing, the other follow-up would be an FCOVD optometrist. And she's already seeing one already. She's actually seeing the one in Chicago. If you've never read the book, The Ghost in My Brain, that will tell you what a real significant head injury is like, and how prism glasses and optometry can help. And that's why Dr. Wojciechowski is coming to Phoenix to teach us how to do that, because until 2 years ago, when I got prism glasses, when I started seeing a patient that I sent to one of these visual development optometrists, I had no idea what a profound effect that prism glasses and the visual system have on balance and the musculoskeletal system. Patient number 2 also came to a seminar, same sort of complexity, but different mechanisms, and also slightly different symptoms. This patient didn't have the eye symptoms, no light sensitivity, severe right occipital headaches, SI joint pain, midscapular pain, neck pain. She had, what did they do for her? She had all passive care. So the treatments that she had were facet injections, epidurals, RF of the facets, occipital nerve blocks. I guess that was kind of it. Notice that it's all passive. Nobody did anything active with her. When we were in Chicago, she got treated at the end of the day. She came in with her pain, I don't know. Pain was, oh, come on. Pain was probably 6, 7, 8. And she's pretty stoic, so that's a real number. So the treatment, I'll show you. I reduced the pain to a 2, 3, 4. And we treated her every night. We treated her, I think, just Friday, Saturday, Sunday. So she had probably 3 treatments. And as we were leaving Sunday night, she bought a custom care for herself and her daughter. And her daughter said, "Oh, and I'm really hypermobile," and proceeded to push her thumb clear back onto her arm. That's Ehlers-Danlos. That's genetic. So after the daughter demonstrated it, I turned to the patient and said, "Are you hypermobile?" At which point she grabbed the skin on her forearm and lifted it up 5-6 inches. In 35 years of being treated by pain management, PM&R, physical therapy, massage therapy, everybody that treated her, nobody told her she had Ehlers-Danlos. Now, she had some of the symptoms that go with Ehlers-Danlos, anxiety, depression, digestive difficulties, all of that. She was really athletic as a teenager and through her 20s. So there was an undiagnosed Ehlers-Danlos. When she started talking about some of her other symptoms, I did a vestibular screen, and she flunked it. And so she has saccadic pursuit in her right eye. Anyway, so she had saccadic pursuit in the right eye. It bounces like crazy. When we did, so those are the 2 missing links, the Ehlers-Danlos, the vestibular disorder, sensory exam, hyper at C2. Always check when people have headaches up the back of their head, always check sensation at C2. That's hyper. So the treatment was what? Supine cervical practicum, pretty much. Now, remember that when I did the first 3 treatments, I didn't know that she had Ehlers-Danlos, but it's basically the supine cervical practicum that treats facets and discs. Now, by then, she had sent me her imaging, and she does have facet degeneration, degermation, right, degeneration, facet degeneration, but she also has disc bulges at all cervical levels, C2, 3, 4, 5, 6, and 7. Now, the thing you need to know about the C2-3 facet, it refers pain to the eye and the back of the head. C2-3 disc, I had to look up. It also refers pain to the back of the head, right where this occipital headache is, and then under her jaw. So her pain is not just at right occipital headaches, but it's also under jaw and up the back of the neck. I want you to think about that. Jeez. Jaw and up the back of the neck. Okay. So we're used to, especially at the core level, you're used to thinking about neck pain and headaches in terms of discs, facets, nerves. The advanced, I'm a little prejudiced because I have been knee deep, neck deep in the vagus for 5-6 weeks doing the vagus presentation for the advanced. And the vagus comes out at the jugular foramen, up just behind your jaw, just behind your ear. It has a branch that goes under the skull, joins up with the meningeal artery, and innervates the back of the skull. So the meningeal branch of the dura goes to the back of the skull. The dura inside your skull actually is innervated by 3 different nerves. So the trigeminal nerve, the facial nerve, and the glossopharyngeal nerve, and the vagus all innervate the dura and the upper 3 cervical nerves. So the dura, when she has this awful headache, the dura is involved. The other thing that I found out is that the dura is sensitive to stretching, which will produce the sensation of a headache. The meningeal branch of the vagus follows the meningeal artery, where that artery feeds just the back half of the dura. So this is a patient I haven't seen in 20 years. Maybe I saw her 25 years ago or somebody like her, and I just missed it because this is not anything I've ever thought of before. So she has very limited range of motion in both the dura and the neck. Think about neck range of motion. Is the cerebellum going to let you move your neck full range if the vagus is adhered to the fascia? Look at the fibers of the vagus. They go from the base of your skull. There are multiple branches. Where is that picture? There are branches of the vagus that go to the vocal cords, the larynx, the pharynx. The vagus controls all of the muscles of speech and swallowing. The vagus is everywhere. We think of the vagus as it enters the thorax because it innervates the esophagus, the heart, the immune system, the spleen, the stomach, the gut. But there are multiple branches of the vagus. I thought I imported a picture, but I guess I didn't, that are up in the neck. Well, when you have heart surgery, whiplash injuries, neck surgery, sore throat, sinus infections, anything that's going to cause inflammation that will cause adhesions, your vagus is stuck to this. How do you increase the range of motion? We treated for scarring in the vagus, scarring in the fascia. That increased her range of motion. Somebody called this afternoon and asked, are we going to talk about concussion in vagus? And this is from the core seminar these days. 94 and 970 with 200, trauma, paralysis, allergy reaction, the basic medulla for the concussion protocol. But then you quiet the activity of the medulla, 40 and 94. Why would you do that? It's because the vagal nuclei, the nucleus ambiguus and the nucleus of the solitary tract, I think, are all in the medulla. So you want to quiet, the way to quiet the vagal nuclei are to quiet the medulla. We don't have a frequency for the vagal nuclei. We have a frequency for the medulla. So that's probably why the concussion protocol does such a good job. Do the concussion protocol 140 and 94. Then do the rest of the concussion protocol. Treat the pituitary 6.8 and 38. And then the stress centers in the brain will turn off the vagus when there has been physical tissue injury. When there's been physical tissue injury or infection. So stress centers in the midbrain, 89, turn off the vagus so that you can survive physical trauma and infection, because the vagus quiets the immune system. So you want to turn down the stress centers, assuming the physical trauma is repaired and the infection is gone, then turn the vagus back up. So trauma in the vagus, increased secretions in the vagus, vitality in the vagus. So a lot of people seem to have read Porges's and other people's theories about the vagus and the dorsal vagal nuclei. The basic challenge with that is it's not anatomically correct. Once the vagus leaves the skull, there's only one of it. There are two different vagal nuclei in the brainstem, and each one of them does slightly different things. But once it leaves the brain, it's 109. In the brain, it's 94 in our world. So that was an interesting concept for this patient. Now, we treated her in, where was that? Chicago. And when she got to Portland, so I told her, it's like, okay, nobody has ever done anything active with you. So she is come to Portland, and she's doing physical therapy, OGI style with exercise. And I've been treating her all week. And this pain at the suboccipital area is persistent. When I treat for scarring, helps immediately, but makes her flare up. That's not normal. So we always run a supine cervical practicum effectively. So the neck pain protocol. So facets, discs. I don't know that many people that have a C2-3 disc. Then we treat manually scarring in dura. And that actually made her neck worse. I got her to an optometrist, the FCOVD optometrist, and just the exam made her nauseous and unbalanced. And most of you know at this point that I've got Meniere's. I was motion sick for 3 days after this exam. They challenged the brain and moved the eyes, and it took 2 meclizine to get her home, and she flunked it. She always feels as if she's back on her heels. Her posture is pretty awful. So she leans forward with her hips and then rights her trunk. And that's vestibular. When we did the ophthalmic exam, the optometric exam, her weight and her balance shifted back and forward. So I've treated her 5 days in a row now. No, 4 days in a row. And every time I treat scarring in the nerve, inflammation at the nerve, helps at the time, but she flares up horribly a couple of hours afterwards. Today, I thought, well, scarring in the dura. If you move her knees, she's laying on her back, she's got her knees bent, and you rock her knees side to side, she's got 10 degrees of motion. That's not normal. And I said confidently, oh, that's scarring in the dura. I did scarring in the dura. It made her headache worse, made her neck hurt, and the range of motion in her legs would not change. So if 13 and 443 didn't change her basically sacral or pelvic range, then it's not scarring in the dura, right? But what else would do it? The question is, so take it apart. Why is the cerebellum stopping motion in the hips and neck, actually? Why is it? It's totally unconscious. You would get her knees across 5-10 degrees, and the muscles would just stop the motion. Why is the cerebellum doing that? It's totally unconscious. What controls tone and balance? Inner ear. Inner ear could do that. So I did 40 and 44. Quiet the inner ear. And I didn't expect it to work. And the range in the, I guess it's not hip range, but range of motion in the pelvis, I guess, increased to 20 to 30 degrees. That was a complete surprise. So her glasses are coming tomorrow, we hope. In order to fix her neck, she's going to need vestibular therapy, prism glasses, we hope, physical therapy. But what we found out was anything that we did, any of even anything, the slightest physical strengthening or mobilization increases your pain. That was interesting. The other thing that I did that worked today was 40 and 396 up the back of the head, neck to top of head. Then 81 and 396. Oops, looks like we lost the internet. No? Okay. 81 and 396, because the nerves in the back of the head could demyelinate. And she had the oddest way of describing. So the pain at the occiput at her occiput and behind the jaw, she described as fullness that becomes pain. And we're talking 7, 8 out of 10 pain. And this is 30 years. So this has been going on for 30 years. No matter what anybody does, unless they actually use lidocaine, that's been painful. So we ran 81 and 396. And then you see this word fullness? See that word right there? That word? Take it apart. Think about what you know about the vagus. The dura is sensitive to stretching because the vagus has stretch receptors that go to the blood vessels at the back of your skull. See that? This feeling of fullness that she pointed to was right at the jugular foramen. So the take it apart part of this is, oh, it's almost time to go. The take it apart part of this that we did today was not just 81 and 396 to correct the demyelinated nerves, but 81 and 109 up the back of her skull. And that took the pain down and did not increase her pain. So when it's not scar tissue, we really have to consider the possibility that it's a denervation. And you're going to hear this in Jody's lecture on CRPS, that nerves demyelinate. And when nerves demyelinate, they become painful. It's like phantom limb pain for your vagus. And speaking of phantom limb pain, let's go to the next one. And this is a lady who had a pancreatic biopsy 2 years ago, completely healthy, never a sick day in her life, no pain, no nothing, completely healthy. They had an abdominal CT looking for something. And as an incidental finding, maybe it was a kidney stone, they saw a dilated pancreatic duct. It was an incidental finding. She had no symptoms, her enzymes were normal, everything was normal. But they wanted to do a pancreatic biopsy to the duct to rule out cancer. Biopsy was negative, but after the biopsy, she had severe abdominal and epigastric pain, rated at a 9 or 10 out of 10. Horrible. Enzymes were not elevated. She has never had pancreatitis. Enzymes were not elevated. After the first visit, she mentioned the pain is worse at night. Lyrica helped. She has no appetite. The vagus regulates appetite. So I want you to look at, we're going to go through this really quick and we'll do more of this at the advanced. The vagus anatomy, the vagus has motor fibers that start in the nucleus ambiguous in the medulla. There's the nuclei there. It regulates speech and swallowing. Esophageal plexus, the cardiac plexus, the vagus follows the esophagus through the diaphragm. And here it is. The visceral sensory fibers. There are small unmyelinated afferents, or nerves that go from the stomach and intestines, liver, pancreas, and spleen up to the brain. Stretch receptors in the stomach respond to volume, carry unconscious non-pain sensations of hunger, satiety, and nausea. Visceral pain from the heart, esophagus, apparently the pancreas. Those join larger myelinated vagal afferents, right? So this patient, think about, all right, general sensory, you don't need to know that one. So this patient, what is the mechanism? So think through it. No. So biopsy does what? Takes a chunk out of the organ, right? All right. If the vagus has pain fibers, and it does, and the biopsy cuts that nerve, what's it like? It's like phantom limb pain for her pancreas, right? Pain worse at night is always going to be central. ortholamic. So that's going to be 40 and 89. So I used one machine on her that was 40 and 89. And then what's the problem? There was one machine that treated the pancreas. Contacts in the back and the abdomen. This one was from the neck to the abdomen. And then, if the problem is a missing chunk of pain nerves in the vagus, then the solution is going to be to treat 94, 124, 81, and 49 in the vagus. Now, she's unfortunately one of those people that doesn't do well. I mean, doesn't have any sort of miraculous change in symptoms while she's on the table. But after the first treatment, she had the best day she's had in, I don't know, a year, 2 years. So we're going to give her a custom care tomorrow. Why is this there twice? I copied those slides twice. So that's how you take it apart. Okay, why does she have this horrible pain in her abdomen? Well, all they did was send a tube down her esophagus, through her stomach, little teeny fiber down the bile duct into the pancreas, take a little chunk out with a little grabber, little biter that bites the tissue, brings it back up through her mouth or nose, and found out she didn't have cancer. So it's not like she had a big scar in her abdomen. There's no scarring. It's just there's this chunk missing out of the organ. It's like it had to be phantom pain. And 9. And then she had a very good day. No pain last night. So looks like we might have gotten lucky. And then this is a lady that was diagnosed with chronic fatigue 30 years ago. And it turns out she was just a 40 and 10 patient. So she didn't have chronic fatigue. She never had ME, as they say in England, never had myalgic encephalopathy. What she had was 40 and 10. And she was pain-free at the end of 60 to 90 minutes, stayed pain-free over the weekend, was pain-free again when she came back on Sunday. So that's what we do. You guys are changing medicine one patient at a time. These are 3 patients that'll never be the same, 4. And you all are changing patients' lives in ways that will change the world. So I'm incredibly honored to be associated with all of you. Thanks for coming, and I'll talk to you next time.